Hi, I'm Dr. Scott Worden, the TOS guy. Welcome to our new live stream. Today we're featuring again Steve Talajkowski. Steve trained for more than a decade with the famous and revered Peter Edgelow, and he learned the Edgelow technique for treating patients with Thoracic Outlet Syndrome. He's now the man who carries the torch for the Edgelow technique, and he's refined it and adapted it himself. Today, Steve would like to go over his previous two discussions we've done live streams on, because we've received some additional questions. And he also wants to bring everything together and lead into his third talk, which involves posture. So Steve, good afternoon.
Hey, thanks, Scott. Thanks for having me here. So today's talk is going to be about posture in the INVEST program, and then we're going to do a summary at the end. Scott's already mentioned a few things. I wanted to just remind people, since I brought this up in the first visit, or the first discussion. I've been a physical therapist for 27 years. I work in Hayward, California. I work for a company called Select Physical Therapy. I worked with Peter for 14 years, and I've worked with TOS patients for 22 years. So I'm using the INVEST program. That's the Edgelow Neurovascular Entrapment Syndrome Treatment Program, but it's referred to Edgelow Neurovascular Self-Treatment Program. So if you remember last time, we talked about so the ABCs are principles that sort of guide the INVEST program. I'm not giving specific exercises in this discussion. It's too difficult. There's too many things that could go wrong. Not that the exercises are dangerous, but they need sort of supervision and mentoring and coaching. So I'm going to give you the principles, which I think are very important, and they would probably apply to other exercises or treatments that you might try as well. So last time we talked about the breathing, which is the diaphragm breathing versus the upper chest breathing. And of course, the goal with that is to relax the scalene muscles. We talked about cardio. And this is the advantages of exercise, urban conditioning, movement, and physical activity. Today, we're going to talk about the core. We activate the core, which is to help maintain posture and then to reinforce the diaphragmatic breathing. So what are some of the functions of the core muscles? We've already talked. Important in postural control, breathing actively. We talked about session. Joint stabilization. They can stabilize the spine. There's also postural muscles, if you want to call the rotator cuff, in the shoulder. Also muscles in the hip. It's also important in movement generation and energy transfer. You cannot move your arms or legs unless you have a stable core. And also it's involved in continence, and ball and bladder. Let's first go to the deep core muscles. We talked about the diaphragm last time. The diaphragm is a breathing muscle. You can see here, it's that dome-shaped muscle that attaches to the rib cage. When the diaphragm contracts, it flattens out. It stays so the take a breath in. The transverse abdominis muscles are the muscles that are the lower layer of the four abdominal muscles. We're going to talk about the other ones in a minute. But that muscle comes from the front of the abdominal area and wraps around to the spine. We have the muscles of the pelvic floor, which again, we talked about continence, bowel, and bladder control. But since they're also attached to the sacrum, they're also involved in posture. And lastly, we have the multifidus muscle. The multifidus muscles are actually the group of muscles, not one. It's a group of small muscles that are attached directly to the back of the spine. If we go to more superficial core muscles, we have the internal and external obliques, not to be confused with the muscles we had last time, which were the internal and external intercostal muscles. We also have the rectus abdominis, which is the six-pack, the muscles that come here. Again, look back at the internal, external obliques. They go on an angle, and over here on the left side is the transverse abdominal muscles. Lastly, again, we have the erector spinae muscles. Again, it's a group of muscles that go all the way from the sacrum to the base of the head. Those muscles are used for maintaining postural alignment and also extending the spine or bending backward. So what I want to talk about is the effects of a slouch posture. So if you look at the picture on your left, there's a lot going on here. First of all, we have a flexed spine, both in the lumbar and upper thoracic area. So the problem with the flexed spine is, if you look to the right here, is the effects on the discs. When the spine is flexed, there's more pressure on the front of the spine. You have to remember that the discs move. Okay, so they change shape. That's the only way that you can actually move the spine, is by changing the shape of the disc. So we have an anterior pressure on the front of the disc, and the disc will then bulge backward. That's normal. What's not normal is that over time, that bulge can get bigger and bigger. And if you notice the small hole here, that's where the nerve root comes out. So as that disc bulges back, it can push on the nerve root. And since there's a bony area back here, you have compression of the nerve. Okay. The facet joints are here. We're going to talk about that in a minute. If you look back at the picture again, what we also see is a protracted or forward shoulder. The scapula is forward, and that pushes the glenohumeral joint, the joint between the shoulder and the scapula, into an awkward position. That puts stress on the rotator cuff muscle. Remember, the rotator cuff muscle is attached to the scapula, and it holds that ball into it. So if you start moving, like when you say just even typing, you can put stress on the rotator cuff muscle. That can lead to things like impingement, or even worse, rotator cuff tear. On top of that, we also have a compressed abdominal area. The ribs are down. This is going to prevent diaphragmatic breathing that we talked about so much last week. What it's going to do is, again, reinforce or move to upper chest breathing. You're going to have to use the scalene muscles to raise the chest, upper chest ribs, as well as the pectoralis minor. And if you learned earlier, is that those are two muscles that are critical in maintaining the space for the brachial plexus. We also have a neck position, which we can get into later. Like I said, if your head is up, you're going to put pressure on the facets. If you're looking, you're putting pressure on the discs. Either way, it's causing a problem. So what we have is there's a thing called the upper cross syndrome. This is from chronic slouch position. And what we have now is a tight pec muscle and a tight upper trap, which comes laterally from the neck, and a tight levator scapula, which comes from the posterior part of the scapula to the neck. The other problem is we have weak lower trapezius and serratus anterior muscles. You could probably argue also weak the mid rhomboid muscles for the scapula. And what we also have here is weak deep neck flexors, which we're going to talk about later. Okay. So I'm going to go back to that picture again. I've shown this picture more than once of, again, the thoracic outlet. We have the scalene muscles, the first rib, the brachial plexus is going through there. We have the costoclavicular space, which is the space of the clavicle in the rib. Then we have the pectoralis minor, and the brachial plexus and vein and artery goes behind that. So what we're looking for is anything that affects that space is going to cause problems in thoracic outlet. So what are the effects of poor posture in TOS? Remember, there's an increased thoracic kyphosis. That's the upper back, middle back. You have a decreased lumbar lordosis. That's from the slouching of the lower back. It encourages upper chest breathing, which is using the scalenes. There's a rounding of the shoulders and the negative effect that has on the scapula and rotator cuff muscles. And we can also say the pectoralis minor muscle. And it has also improper cervical alignment, which could result in either compression of the disc or irritation of the facet joints, and also just the general positioning of the entire spinal cord and the nerves that come out of the neck that eventually form the brachial plexus. So now we have what's called the lower syndrome, which is just the equivalent of the upper cross syndrome, except it's in the lower back and pelvis area. And again, what you have is a weak gluteus maximus muscle and weak abdominals. We talked earlier about how important abdominals are with breathing. We also have a tight iliopsoas, which are the hip flexor muscles, and a tight erector spinae muscles. So why am I bringing this up? Because if we're talking about posture, we need to talk about the pelvis. If you look at the picture on the left, I'm going to start the video. That's an extreme slouch, but actually I've seen people do that on a couch. If you look at the back, let's do it again. As the back slouches, you get that increased lordosis. An increase in the kyphosis. You got that decreased or compression of the abdominal area, again, which is going to cause more upper chest breathing. But we have the rounding of the shoulders. Again, this whole space, that space where the brachial plexus goes through, in that position is being compressed. And then imagine if the out, it's going to compress it even further. But what's important to remember here is what's happening is the pelvis is wrong. The back and the shoulders and the neck are just responding to that pelvic movement. Why I'm saying this is the only way we could control posture effectively is through the pelvis. It's not through the back. So a lumbar support's important, but we have to have the pelvis rolled forward. If you look at this picture on the right, my intention is to keep the pelvis back arched. Now I'm asking her to round her shoulders. And look how difficult it is. It's difficult because all these other areas, the thoracic spine, the lumbar spine, the pelvis, are in a better position. You can't round the shoulders very well when this is all in place. Just like if you go back to this picture, it would be unlikely that you could pull your shoulder blades back in a slouch position. Go to the next slide, if I can. So here's a more kind of a detailed picture of the pelvic position. If you look at the left side, the pelvis on here where that arrow is, the person's sitting on the flat part of the pelvis. There's a rounded part here. Oops, sorry. Okay. There's a rounded part here, and there's up here, and there's a flat part here. When you're in this position, the pelvis rolls forward, and it creates that lumbar lordosis automatically. You can support this with a pillow, but this has to happen first. When the pelvis rolls backward, like when we're slouching, let's say you're sitting on a couch for sure, that lumbar lordosis flattens out. A pillow here is not going to create more extension. In fact, what some people will do is, arching this way, they will arch their back at that mid-lumbar level. They create their arch not down here, but further up. There's a problem with that because it puts extra stress on the back. And if we remember the same problem we had with the neck, extending, you put pressure on the facet joints. So what are some of the reasons for poor pelvic positioning and sitting? Well, first of all, not knowing the proper pelvic position. Also, poor control of pelvic and core muscles. We're in a position where the abdominal muscles are not active. Okay, remember that. And also the gluteus maximus are not active. We have improper chair, and that could mean all sorts of things. The chair height, the size of the C-pan, the back support, whether you can even get your back against the back of the chair, the armrests, are they too high or are they too low? Are you using the armrests to make up for the fact that your arms are reaching out? Okay, actually, how far is, or how easy is it to adjust the chair? And then we have the tight hamstrings and hip flexors that we talked about, or the hip flexors in the lower cross syndrome. So if you look at these pictures again, we have a position where the good posture is on the left, obviously, is you have the back position, you have a little bit of a lumbar lordosis, a little bit of a thoracic kyphosis. I personally would rather have the arms even closer in to the side, but they're better than the other picture. And the head is in upright position. It's neither flexed or extended. If you look at the right side, you have, again, that flexed lumbar spine, that flexed thoracic spine, a rounded shoulder compressing the front. You have a compressed abdominal area, which is causing the person to focus more on upper chest breathing. The arms are reaching out, and then the neck is hyperextended, causing pressure on the facet joints. If we go this way, we have almost the same problem, but instead of a hyperextension at the facets, we have a flexion, which is going to cause problems at the disc. We're going to go again, upright posture, it's alignment. Ear over shoulder, over hip. If you're sitting, everything from the hip up would be exactly the same. You're only bending at the hip. So leg comes out at 90 degrees in the hip flexion, the knee is 90 degrees, like we're having in this picture. Earlier in the upper cross syndrome, I mentioned the deep cervical flexors. We've seen this picture before too. What we have here are the anterior and middle scalenes, and the brachial plexus is running through there. That's the first rib, okay? The muscles that we're concerned about here are the deep neck flexors. Those muscles are attached directly to the spine, okay? If you said earlier, noticed in that upper cross syndrome, these muscles are weak. And with people that have an upper chest breathing pattern, these muscles are actually overused. They're hypertrophied. So what we have is actually a muscle that's supposed to be strong is weak, and a muscle that's not supposed to be overused is being overused and it's almost too strong. So we have an imbalance between the deep neck flexors and the scalene muscles. So what we see here is you have a person with upright posture is that the head's neither down or up. And so what's happening is that we're using both the anterior deep neck flexors and the posterior muscles equally. If you're looking down, you're just resting on the facets, or the discs, and stretching the ligaments of the spine. If you're looking up in that position we had earlier, you're using the upper cervical muscles, the ones that are right below the suboccipital, the ones that when we're overused cause headaches. In this case, it's a balance between the back muscles and the anterior muscles. And also what happens here is this space, the space where the brachial plexus travels through the scalenes, underneath the clavicle, and through the pec minor, that direction is straight. There's less areas where there can be compression. I want to mention one more thing about it's called sequencing. It's the concept that the inner core and core muscles must activate first to stabilize the body before movement of the outer core and prime movers of the body can effectively move. So what it means is that the core muscles have to activate first before you do something. Now that's an obvious when we're talking about lifting a heavy box, right? You would widen your stance, you tighten up your stomach, your glutes if you knew how to, and you grab that box and pick it up. But the same thing is going to happen whether you grab your cell phone across the table. I would argue the same thing is going to happen to a lesser degree if you're sitting at a desk typing, using a mouse. We still have to engage the core muscles. If we engage the core muscles, then the other muscles, the shoulder, rotator cuff, they can move more effectively. So I wanted to talk about a few things of like, why did I bring all of this up? And like, oh, where are we here? So I want to make sure they understand that Thoracic Outlet Syndrome, there's a spectrum. There are some people that have mild symptoms, and there's some people that have devastatingly severe symptoms, okay? But whatever the symptoms are, if you have TOS, there's compression between the scalenes, the costoclavicular space, and or the pec minor muscle. That is thoracic outlet. If there's no compression there, you don't have it. Next is that most people, no matter how bad they are, or most people will not have surgery. The result is that we're left with conservative treatment. Since this is a compression problem, it's an injury, a compression of the nerve, brachial plexus, or the vein and artery, we have to focus on decompression or opening the space or spaces. Correct posture and breathing techniques are an effective way to open the space. But it's not easy. Some people already have anatomical problems. They have a narrow scalene triangle. They have a rib abnormalities, a bigger rib and extra rib. They have a tight pec minor or a decreased costoclavicular space. So posture is not the only problem, but posture can make that problem worse. And it's one of the things, or probably the only thing, that as a patient, one has control over. Remember, that space is small, but there's not a problem until the nerve is irritated or the vascular system is compromised. So if they went back, would see that they have narrower spaces before they have symptoms. It's not until the nerve gets irritated that. So with mild conditions, most people don't do anything. It's only when their condition gets worse that they seek any help. If you go to medical, if you seek medical help, for some people, if enough tests are done, you will find something. It could be cervical problems, it could be shoulder problems, it could be like peripheral nerve injury, carpal tunnel, ulnar compression. But for some people, those treatments aren't effective. At the best, it's a waste of time. At the worst, it can be worse. If you go to a doctor or to a medical expert and they don't find anything, you might be dismissed as being a hypochondriac. There's nothing there. On the other hand, you might go to somebody and they might look at those things that we talked about earlier in the upper cross syndrome, tight and weak muscles. So what happens? Well, sometimes those things could work. But my experience is the people that I see, the people that come to these presentations, I think, the people that call Scott or see Tracy Newkirk, those things haven't worked before. The approach has failed. And by the time I see somebody, what I have is a person with a chronically irritated nervous system. And when that nervous system gets irritated, it's not only at the scalene triangle or the pec minor or the or at the collarbone clavicle. The nervous system gets irritated. It gets irritated centrally, in the spinal cord and in the nervous system, in the brain's system of regulating and interpreting pain. But I also see people that have a chronic tight and weak muscle in the upper cross syndrome. They have a dysfunctional breathing pattern. But that doesn't mean that we start there. What we have to do is we have to treat what's happening now is a highly irritated nervous system. The problems that we talked about before, muscle weakness, muscle tightness, this is not the time to start treating them. What we have to do is to treat the nervous system first because it's irritated. So that goes back to what I said in the first talk. We need to relax, open, and calm. Relax the muscles around the nerve, open the spaces around the nerve, calm the nerve down. If we can't do that first, the chances are that more exercise is going to make it worse. So I have a last slide to show. This is from Peter. He called it it was a pie chart, and it is a pie chart. Of course, the letters that spell pi are actually in the chart. So physical, intellectual, emotional. So ironically, PIE is also Peter's initials. But what we're talking about is there's three ways to look at treatment. There's the physical part of it. That's the exercises, the actual things that we do to treat a specific problem. And I want to make sure problems are different for different TOS patients. The reason I brought up things about the rotator cuff, why I brought up things in the spine, is that people can have overlapping problems. They can have problems in their low back. They can have problems in their low back that can limit their ability to walk or to do exercises in the program. So we have to address the part, and that's what most are looking for. But we're also looking for is the intellectual part. The intellectual part of the program is understanding the problem. It's how to build and sustain a program over time, and to keep diligent, to develop new habits and to break old habits. How to assess your progress, also objectively assess your progress, and how to make changes to your program depending on how things are going, either that day or over time. Probably the most hardest part is the emotional part. It's learning how to deal with chronic daily pain that sometimes is 24/7. It's dealing with a medical system that dismisses your injury, or at least doesn't have an answer. It's how to manage the stress of not sleeping or not being able to do even basic tasks at home, like making a meal or picking up a child. It's feeling like you're not in control, but more likely is not just not knowing what to do. So when we use the INVEST program, we have to look at each aspect of the person's body. And it's not just a series of exercises, although it is important to do the right exercise. That's an important part, but we have to address that, but the other issues or the other things that we have to look at. So anyway, I'm pretty much done with my presentation. I don't know if anybody has any further questions. Oh,
Moderate descending and
okay, here we go. What's the question? What's the most important thing that I can do regarding posture to help with TOS? I think there are some good books on posture out there right now. There's one called The Age of Spine. There's 8 Steps to a Pain-Free Back. I think the most important thing is we have to control the pelvis. So we have to look at everything that we're doing regarding sitting. I hate to say it, but a couch, I see a lot of patients, especially now, where people are working from home for COVID, and they're sitting on the couch. They don't have an office, or they sit at their kitchen table and they're putting their laptop on their kitchen desk, on their kitchen table. So I think the most important part is we have to get in a position where the pelvis is supported. I didn't really get into it, but there are seat wedges that help tilt the pelvis forward, and do is I put like a lumbar support after that, so that you can get the pelvis forward and then the lumbar supported. And at that point, you can kind of relax your shoulders. So what I don't want people to think about is, I was talking a lot about weak muscles and tight muscles, but if you're talking about posture now at the beginning stage, we have to keep thinking about relax, calm. So you don't want to open the shoulder blades by pulling the shoulder blades back. You want to relax the shoulder blades by getting the posture and lower back in a good position. We can work on the strengthening of the posture muscles and the strengthening or the stretching of the muscles like the pectoralis minor later. really focus on is calming down the nervous system. Otherwise, everything we do just irritates it further, and you're just digging a deeper hole for yourself. Another question, I think I'm too far gone for conservative treatment. I have engorging and swelling and burning. Do people fail conservative often? I would say no. I mean, I've seen some pretty severe patients. I mean, it's that have gotten better. I think the reason a person would go the surgical route is that they just have findings, MRI findings that just show that that space is just too small up through just posture and breathing, and that's truly does happen. The other problem is that sometimes people have second problems, cervical problems, shoulder problems, and so all those things together just magnify each other. So I think there is a reason to sort of look at cervical problems, shoulder problems, but the treatment of those cannot aggravate the TOS. So I usually suggest to people is just take care of the TOS stuff first, or at least calm it down far enough so that we can treat the neck and the shoulder. And a lot of times you treat all three of those things and things get better. Can obesity be a factor with thoracic outlet syndrome? To be honest, I haven't seen a connection with obesity and thoracic outlet. I mean, I have plenty of patients who are not in any way overweight. I think it has more to do with the anatomy. I think it has, I would say, posture, but I think a lot of people have poor posture and dysfunctional breathing patterns that don't have thoracic outlet syndrome. So I think the problem is that we have this narrow space that we probably already had, and through posture or poor posture and dysfunctional breathing, we've taken away even more space, and you don't have more space to give up. So we have to maximize the space that you have. And I don't think, obviously, obesity might have other issues, but I don't think as a factor for thoracic outlet, I've seen it being a problem. My TOS pain gets much worse when I'm feeling stressed out. My physician insists that there's no connection. Could I be imagining the extra pain? No, you're not imagining it. I mean, the stress is a huge factor. I think I said earlier in my pie chart that managing the emotional part in some ways is just as important as managing the physical exercise part. Stress does stimulate the nervous system. It makes the nerves more sensitive. It decreases the threshold that pain fibers need to fire. So I think stress is probably one of the bigger factors in treating this. Obviously, I think the exercises help. If I can't control stress, I think it's a battle to control the condition effectively. So it's not in your mind. Of course, and it does play a huge part. So that's why I think even the whole fact of diaphragm breathing and meditation goes along with stress management. I have a shoulder injury. I have been recommended to wear a brace for the shoulder. What are your thoughts on wearing braces? I'm not sure what kind of brace you're talking about. I certainly wouldn't wear a sling. I don't know if that's what you're talking about. There are some braces that control stability of the shoulder. That would be probably okay. Tracy Newkirk has a significant effect on the shoulder blade positioning, and those work very well with TOS patients. So I don't think there would be a problem with a shoulder brace. I would just make sure that it's not forcing a person back. It's not putting pressure along the neck where the like thoracic outlet is, pec minor, clavicle, neck. And Obviously, if you're wearing it and it seems to be increasing your thoracic outlet symptoms, I'd say back off on the tension of it. There's no way that a person should be using the no pain, no gain approach with this. If it hurts, nervous system wise, it's a bad thing. So Scott, did you have something to add? I wanted you to come back in again.
Hey, Steve. It's really great to see that integration with the whole rest of the body. There's literature from back, as far back as I know, from 1912, about people talking about the positions of the shoulder girdle when you're very young, when you become a teen, when you become an adult, when you become older. So for me, that's very educational to see how the balance has to change and how the muscles react. The muscles become weaker or stronger. First question I wanted to ask you is, a laptop is a form factor that obviously prevents you from doing the right thing. So for your people, especially now, we're all working from home digitally. Well, what do you advise when they only have a laptop to work with?
Well, first, what I usually do is I ask people to elevate the laptop to a position that is, say, their desktop screen would be at. And then what you need to do then is to get external keyboard, Bluetooth or some kind of like a keyboard where you're using the keyboard away from the laptop. And then, and the idea would be is that keyboard would be as close to your lap as you could get. I don't know if it was if I showed it quite or just talked about it enough, but when a person's arms are reaching out, even just a few inches, you're engaging the shoulder muscles, you're tightening up the pectoralis minor muscle. So the arm should be kind of at your side, almost like if they're literally in that alignment between your ear and your hip. Putting that external keyboard away from the laptop is you can position that keyboard in that way. Some people like a split keyboard that takes some time used to, and some people aren't always willing to invest the time because they're usually under the pressure to get work done. And also maybe the mouse should be closer, because every time you're reaching out to use a mouse, again, you're doing the same thing. You're engaging the shoulder muscles, you're putting stress on the brachial plexus, you're just causing more trouble. So, but I say first thing is elevate the laptop.
Put it up
right now, my computer is on a old Instapot box on my table, because otherwise it would be way down by my knees. So I have it more level in my eyes. So you just find something around the house, literally a box.
How about these standing desks? I happen to own a standing desk that moves up and down, and they change positions every hour or so. Have you had any experience with your patients?
I mean, there are people that like standing desks, and I think the people that I see that seem to prefer the standing desk are people that have low back pain, and there can certainly be instances where a person both has thoracic outlet and low back pain. So, the standing desk could be the answer for that. I think maybe the idea of just standing up for periods of time, could be helpful just to kind of change position. But I would also have to say that my also feeling is that people tend to, they get it, but they don't use it as much as they probably think they would. I still think you can maintain an upright posture from the hips up sitting.
Mm-hmm.
But I do agree it's harder. So there might be an advantage to standing for some time.
My experience is anecdotal, but myself, I've noticed that, I have to sit for 8 or 9 hours doing some pretty intense work. So I don't pay a lot of attention to my physical selfness. And sometimes when I stand up and get out of the chair, I feel like my legs are full, swollen. And I'm just guessing that the veins where your hips bend may be somewhat compressed, and because of the force of gravity and the low pressure in the veins, that it's harder to drain that way. So standing up allows gravity to kind of flush things down and back up again. I know that's just totally anecdotal, but I have a change in the feeling I have when I stand and sit.
Well, and I think also what you're saying is that, you know, you're being more active or being more aware of just changing position. So just the fact of I'm going to stand up and change position just it gets you out of that sort of cycle of just getting locked into something for hours and hours and not letting go of it. So I think there's probably just an advantage of just, you know, being aware every hour or so of just, I just need to move.
Set a timer.
Set a timer. I mean, of course, there's plenty of programs that have stretching reminders built into them, but.
Very good. How about the explosion in the use of portable devices, iPads, phones? Do you think people tend to use those in a bad postural situation?
Yeah, I mean, if you look back at the pictures I showed earlier, where, you know, we're in that kind of forward bent position, I think the effect on the cervical spine, the effect on the rounded shoulders, the effect on the low back is going to be dramatic. And I don't know what the future is going to bring, but I would imagine that we're going to see more problems as over time, and problems in younger patients, I believe. So I think, you know, the idea of holding up the phone, I know it doesn't sound, it seems kind of like, how do I do that?
People don't do it like you did it, Steve. People,
yeah,
they let their head fall forward into the phone.
You know, so I think there has to be some realization that that's going to have an effect. And if you include, like most people who I work with who are working at a computer all day, 8 hours longer, 9, 10 hours, and then on their time off, they're home and they're on their phone or their tablet. And the neck and back don't see this as work and pleasure. It just sees this as stress to the neck and spine. And if you're taking 8 hours of work and throwing on 3 or 4 hours of phone use, that's a lot of time where the body is going to develop those patterns that I talked about earlier.
Great points.
One question was, do I recommend elevated chair armrests to lift the shoulder girdle while at workstation, or no armrests at all? Go for the no armrests at all. I think if your arms are back at your side and the keyboard is closer to your lap, like a keyboard tray, there wouldn't be a need for any armrests. I think the other concern is by putting pressure of the interior part of the forearm where the ulnar nerve is, and by resting your arm on a armrest, you could put compression on the ulnar nerve. Just to see people rest their hands on the edge of the keyboard, there's a talk about, you know, even wrist rests, but there's still a feeling that you're compressing the carpal tunnel area, and that while it might be relaxing to the shoulders temporarily, the long-term effects of that compression could be worse. I think the better answer would be is to move the keyboard closer and let your arms hang so you're not lifting them up. Now, we have talked before about elevating the shoulder to open up that costoclavicular space. But I think you would do it in a different way. And I don't think that's necessarily the way I'd work.
Also, while I'm here, I do want to remind our viewers that next week we have a cool talk with Dr. Farid Garagoslu, who's a surgeon in Orlando. And Guy has evolved from following the traditional TOS surgery to developing a radical new method using robotic surgery. And he's had awesome successes. And he and I have had many good discussions about the etiology of TOS and how our understanding is evolving. So that should be next Thursday, the 12th, and I will be participating. We're actually going to talk about the history of TOS, but I find that fascinating because there's so many people who have had all these different ideas for 200 years now. They didn't have the technology we have either in diagnosis or treatment. So they had to take reasonable guesses based on their patients' x-rays when they came along, which are really rudimentary, autopsy studies, figuring out the anatomy. So it's going to be a really good talk next Thursday, and I want to just plug that for anybody who's here. And there we go at the bottom. Fareed Gargaso. He's a great guy, really smart, really willing to question dogma and push things forward. So hopefully people will attend and love what we're talking about. It's got a lot of great stories too. The history of TOS has a lot of very famous people in the medical fields, and some good human stories in there too. So Steve, any last words about what people should do when they think their posture is being affected, when they think they're working unergonomically? Should they contact you?
Of course they can. I'd be happy to help. And I want to reiterate, and because I hear this every time, I shouldn't say it every time, but I would probably say every time actually, is I think people, if they start stretching and strengthening and they start to have an increase in their symptoms, it's not the right approach at that time. And I think people just continue to do it because they feel like they have to work through it. They have to, it's no pain, no gain. I just cannot stress enough that the more irritated that nervous system gets, the harder it is to treat. You start having, atrophy, hypertrophy of muscles. You start getting scarring around nerves. You start getting damage to the nerve itself. And it's all because we continue to irritate the nerve. I'm convinced that people could get better if they catch them sooner, and they could do the right treatment. I just feel like we're getting people here because they failed so many times, but they've also have dug a deeper hole for themselves.
Yeah.
And much harder to get out. And there's nothing wrong with just looking at with using the approach of relax, open, and calm, at least to start. Later on, we'll get into stretching and strengthening. That is part of the program. It's just not where we start off. So all the things that I'm saying people can do, postural, breathing things, even though I'm not giving you the INVEST program, you can do those things today.
And of course, you're bringing up early awareness. We need to keep spreading the word. As people
Right.
are watching, hopefully they go back to Facebook and their other social groups and they let people know. So part of our job with doing this with experts like you, Steve, is not just for understanding, but awareness. People come to you faster. They start considering TOS, even if they're not exactly right in the end. Getting on that elevator first is pretty important.
Yeah.
Awesome. All right.
Okay,
So you can contact me, and through me, you can contact experts like Steve through our website, www.tosmri.com. This website, toseducation.org, is great as well. And you can follow us on social media on Facebook, Twitter, Instagram. We are TOSMRI. Easy to remember, I hope. And we look forward to helping everybody.
Yeah, thank you, Scott. Thanks for doing
That's
this.
great. I think this is the best talk you've given so far, and I hope we can have you come back and get more.
Oh man, yeah. I can only go better. Can only go up, right?
Yeah, well, that's great. It's so good to listen to you. I learn a lot, and I hope everybody else here has too.
Okay, well, thanks again for having me.
Thanks. All right, we'll see you soon.